Hi, it's Dr. Sandy Laura Kramers. Thank you again for joining us for the EYE show. This is episode 34, and I'm one of the surgeons here at Visionary Eye Doctors. Thank you to all of you who have subscribed to this podcast and pass it on to friends and family. And I encourage you to please continue to pass it on to friends and send us suggestions for future podcasts. And thank you to those who have sent us suggestions and also sent us patients. So thank you very much for that. So today we're going to talk about part 2 of glaucoma, which we talked about in the previous podcast. And glaucoma means optic nerve damage. And this is one of the most common causes of preventable blindness in the world. It affects millions of people around the world globally, and many types of glaucoma are preventable. So we're going to talk a little bit about how we test for glaucoma, who should we test for glaucoma, how we test for glaucoma, and just to review again some of the medications. So just to show you again here what the optic nerve looks like. So here's the eyeball. The front of the eye is called the cornea, the lens in the eye. There's the iris, the colored part of your eye, whether it's blue, brown, or black, or green. And then the vitreous inside, and the optic nerve is a cable that connects the eye to the brain. It's like your TV cable that gives you pictures. And just like your TV cable has insulation around it to help the electrical impulses, this optic nerve actually does have blood vessels that go through the actual nerve tissue, and also it's surrounded by insulation called myelin. And as somebody develops glaucoma, the actual nerve fiber layer and the myelin starts to decrease. It starts to become affected, and it's the only place in the body you can see a nerve die. And so it's very beautiful in that sense that when we look through the eyeball after we dilate the pupil, we can see the front part of that cable, and it's called the optic nerve head. And so most people, as I mentioned before, have a kind of tight orifice where the blood vessels go into the optic nerve, and that's called the cup. The cup to disc ratio is how we determine if somebody's developing glaucoma. So in this book, it's outlined here a little bit in black. The cup is very small. The disc is the whole optic nerve head, and so it's called the cup to disc ratio. So when we're born, it's usually pretty small. As we get older, the cup increases because it's the death of the aging of the nerve. But when it gets beyond a certain point and it really becomes kind of whitish, yellowish white, yellowish first, usually then white, we know that nerve is actually dying. And so we can determine that by some things that we're going to talk about. So that's what optic glaucoma is optic nerve damage, which can lead to permanent blindness. And so how do you know you should be checked for glaucoma? Well, most times we will check you when you come in. We recommend a yearly dilated exam, at least every couple of years on most patients. If you have any risk factors, if you're African American, you have a family history of glaucoma, hypertension, diabetes, previous trauma to the eye, high cholesterol, smoker, we recommend probably checking at least once a year to make sure we're not missing anything. And so there's some tests that we'll do for that. And so when we're looking at the eyeball, the first thing that your doctor or your eye office, optometry office will do is check your eye pressure. And what they do is they either put a little kind of a puff of air, or actually applanation, or a machine that basically will briefly touch the cornea, which through basically a wonderful formula helps us determine the average pressure of the eye, which usually is about 10 to 21 millimeters of mercury. If that pressure is higher, we correct for the thickness of the cornea. We talked about this before. The thickness of the cornea is important in determining if that pressure is true or if it's falsely elevated. So let's say we have a patient that's 25 millimeters of mercury, but their cornea is very thick. Then we know the real pressure is probably 19 and it might be okay. And the other option would be a patient comes in with a pressure of 19, but their cornea is very, very thin. Well, the real pressure is 25, let's say. So that tells us a corrected pressure is important. The other thing they'll do is dilate your pupil so we can take a look at your optic nerve, and that's essential to do. So the testing for glaucoma is pressure, checking your tonometry, pressure of the eye. The pachymetry is the thickness of the cornea, which will tell us how we adjust the pressure. The dilated exam is very important. We often recommend a pentacam, which is that machine I showed you before that actually takes a look at the angle of the eye, the drain inside the eye that's kind of important, which is located, if we take off this cornea, it's located right around here, and that drain helps the fluid drain out of the eyeball. So the pentacam has been very helpful for our patients. Sometimes we'll do a gonioscopy, which kind of looks like this. A gonioscopy is a mirrored lens that has multiple mirrors on it that allows us to take a look at the drain with a contact lens. So we put this type of instrument on the surface of the eye. We give a little drop of proparacaine, and we will literally put it right on the surface. And when we put it on the surface, if you look in with the microscope, you'll see there's these little mirrors that allow you to take a look at all the different angles around the inside of the eye. So all around, ideally 360, we'll take a look for any tumor, any type of mass, any closure and narrowing of that angle, which is kind of important because of the risk of narrow angle glaucoma. And then so those are the key testings that we do initially, but then there's a whole nother layer of testing that we do. And there's 3 key ones I want to talk about today, which we touched on briefly. The first one is called the visual field test, which has been the gold standard. It's a machine, you put your head in and you push a button. When you see little lights peripherally, you want to look straight ahead. But what we do know is that you usually have a 30% loss of nerve fiber layer before you have a defect, so the horse is out of the barn. And we're going to put a little link to show you what the visual field looks like. But this is an example of a patient behind me that had a optic nerve damage on the bottom of the eye. So if you're looking at my eyeball and you're looking into the optic nerve, let's say this is the patient, in the inferior part of the nerve, the bottom part of the nerve, there was already thinning, there was damage there clearly. And we could see it on the microscope. So when we did the visual field testing, sure enough, you'll notice there's a little bit of this darkness here on the top. So everything is reversed with the visual field because of the mapping of the brain. So that person has glaucoma. We can see that the optic nerve is damaged by the visual field test. If we had caught this patient, let's say 10 years ago, we might have seen a change in what's called HRT, Heidelberg Retinal Tomography. It's a specific test that actually is it's more sensitive and more specific at testing early glaucoma changes. So we prefer to do that test as soon as possible because it'll detect early changes. But again, sometimes it detects it too late. So now there are even more advanced tests such as what's called ERG and VEP, electroretinogram and visually evoked potentials. And those are other tests that pick up glaucoma even earlier. So those key tests are crucial to kind of help us determine if there's true glaucoma or not, or if there's a suspicion, and how often those patients need to be followed. If you have any family history, we're going to probably see you every 6 to 8 months. If there's no family history and there's a low suspicion, once a year is usually enough. So those are the key components of testing. And then now what I want to do is go through, make sure I didn't miss anything. There's a couple more testing treatments or testing options at different academic centers, such as FDP, frequency doubling perimetry, which is more sensitive, but a little bit harder to get. Most doctors' offices don't have that technology, and then every year there's new technology coming out, but each one of these machines is expensive, so most doctors' offices only have a visual field, HRT, and maybe an ERG to kind of test you for glaucoma, and usually that's enough. So let me just go through briefly, just again, the different types of drugs we talked about briefly in my previous podcast. In my video, you saw all the different types of drops that are available. I just want to go briefly through some of the different, just to kind of recap all the different treatment options. We're going to just list them, and just so you can talk about it with your doctor. All these have net positives and negatives. And so the first category are the drops that decrease your fluid that's produced in the eye. Let me start with the fluid drainage. Let's start with that one, the fluid drainage of the eye. The reason why I'm going to start with that one is because that's the one we usually start with in terms of treating patients. So the first category is the prostaglandins, and the most common one that was started was latanoprost, called Xalatan, that's the brand name, travoprost, which is called Travatin Z, tafluprost, which is Xioptin, and bimatoprost, which is Lumigan. So those are the brand names. Most insurances are now not covering these. They're only covering latanoprost, which is the generic prostaglandin, and they increase the drainage. The side effect of the prostaglandin, the biggest one that concerns most patients, is itching and redness and allergy. That's the number one issue. The issue of changing the color of the eye, if you're blue colored iris or green to more brownish color, that's a risk. So we try to remind patients that could happen. Most patients that need treatment really don't care about their eye color because obviously, saving your vision is more important, but it can happen, and some people will try other options before that. The risk of it not working is another risk with all of these. The second option in this category of increased fluid drainage is the Rho kinase inhibitors, which we talked about briefly last time. Repressa is the brand name of Notarsadil, which is one of the new categories. We love Repressa, but it causes terrible redness and itching, and most insurances don't cover it still. Third option is nitric oxides like Vyzulta, which is latanoprostene bunode, which we really don't use that much because it was causing a lot of redness and irritation for our patients, and a lot of insurances don't cover it. And then the last one in this category are the miotics like pilocarpine, cholinergic. We talked about that last time. It comes with a green top. We again don't use this that often because of potential side effects, especially headaches and redness. The second category is the category that decreases the amount of fluid in the eye. This was really the first category that was developed. The number one on that is the beta blockers, which is basically decreasing the fluid production in the eye, but it can have side effects of difficulty with asthma, arrhythmias even. So we don't use it that often, especially in young people. It can even cause depression, impotence, problems with diabetic control. So the category of this is timolol, Timoptic, Betaxolol, Betoptic, which is a little bit more specific to help with this. So your doctor might talk about that with you if nothing else is helping. The second one in this category is alpha adrenergic agonists like brimonidine, which is called Alphagan. It's now, I think, about to become generic. And aproclonidine, iopidine. So we love these because they don't increase inflammation the way prostaglandin analogs can. But they do cause redness and itching, and that's a big issue. They don't change your iris color. All of these can cause sometimes fatigue or irritation. We've had patients say they get a headache with some of these or muscle aches. So everyone can have a little negative reaction to some of these. So just you're aware that can happen with these as well. And then the third one in this category is the carbonic anhydrase inhibitors, such as dorzolamide, which is Trusopt, and brinzolamide, which is Azopt. And again, we like the carbonic anhydrase inhibitors, but again, they cause a lot of redness and irritation. So that's the problem with these drugs, is that most of them have preservatives, like we talked about before. There's only a few of them that don't. There are combination drops that, as we talked about, like Cosopt, Combigan, Simbrenza. These are the brand names of the two combined. And they work better than just the single drops, but they have their side effects. So let's say the drops don't work, or that you're having too much dry eye, which is a big, big risk of all the drops that have these preservatives. Then we talk about the laser, which is called selective laser trabeculoplasty. There's new lasers coming out every year now, but this is the most commonly one used because it's very safe. It's been used now for many years. And the laser basically is similar to this idea of putting a contact lens on the eye. It looks like this. We put in a special laser machine. We put a special kind of what's called a gonioscopy on the surface of the cornea, so minimal discomfort. And the laser shoots through the mirror to basically hit the inside of the drain to make a new hole in the drain. And we put multiple ones of these, usually in multiple quadrants of the eye, to increase the drainage of the eye. So it can be repeated multiple times. Very safe. I've never seen a complication. The only risk reported that I know of is an increase in eye pressure. Otherwise, it's very safe. If the laser doesn't work, then we go on to what's called the minimally invasive surgical glaucoma technology, the MIGS procedures like iStent, the Cahook goniotomy. There's different surgical procedures we can do with cataract surgery, or sometimes now without cataract surgery. New innovations are coming out every year, such as CyPass and all kinds of wonderful, exciting technology in glaucoma. And if those don't work, then we will do what's called trabeculectomy, which is where we make a little drainage on the surface of the eye, the kind of a little bag made out of your own tissue, your conjunctiva, that connects the inside of the eye with the outside of the eye. So there's a little fluid pocket that collects the fluid, so the fluid in the eye that will actually be less, and it drains out of the eye in a somewhat safe way, but the risks are infection, it failing, needing another surgery. So if that doesn't work, then we do a tube shunt, and that's much more complicated, and that's for end-stage glaucoma. And that's where we literally have a plastic bag that's attached to the outside of the eye with a suture. We put a little tube into the eye behind usually the iris, and it literally takes the fluid out through the plastic silicone tube, and then it goes into the bag. And so again, that has its risk of infection, needing another surgery, or it not working. So the goal of all this is to catch glaucoma early. When we can catch glaucoma early, we can save patients misery and a lot of surgery and a lot of expense. So ask your family members, especially at family reunions, does anybody use prescription eye drops? Find out what those prescription eye drops are. Sometimes they don't even know they have glaucoma. You want to check your parents' medicine cabinet and see if they have any glaucoma drops. See if they have any steroid drops. Why did they need that? Why did they use that? You have to find out, because a lot of patients don't talk about this with their family because they don't want to scare them. They don't want to worry them, not realizing that a lot of this is genetic. So this is the key component of this podcast. Please tell your friends and family to ask your parents about the risk of glaucoma in the family. When you're at family reunions, you ask all the aunts and uncles, how you're doing, how's your health. Do you know anybody in the family that has glaucoma? Especially if your doctor's concerned about you, you want to ask about it because it can be something that can save your life and your children's vision down the line. So I hope this was helpful. Please send us comments and suggestions, and I'll catch you next time. Thank you.